Hi, and welcome back to the NCS podcast, Perspective Series. This is Lauren Kaufman, and I'm a neurointensivist at Temple University in Philadelphia. Today, I would like to welcome on the podcast authors from a recent current article, Emergency Neurological Life Support, Understanding Its Applicability and Limitations in Africa. So thanks again for joining me. We have Dr. Morgan Prust, who's a neurointensivist at Yale, and Dr. Ismail Hassan, who's the Director of Neurosurgery at Aminu Kano Teaching Hospital in Kano, Nigeria. Welcome onto the podcast.
Thanks for having us. It's great to be here.
So to start, I would kind of be interested in hearing Morgan talk a little bit about how long he's been involved in international medical education and how did you get started on this path?
Well, thank you again for having us. It's great to have the opportunity to talk about our work. I started in global health, not particularly early in my career. You know, many people in global health, have a sort of lifelong history with it. And for me, it was something that I became involved in over the course of residency. There was a neurologist named Omar Siddiqui who is based at Beth Israel Deaconess Hospital in Boston, but was living primarily in Lusaka, Zambia, which is the capital city of Zambia, which is a relatively small country in southern Africa of about 19 million people. And Omar hosted various American neurology trainees who would come over for a month's time and get an experience of what it's like working in a resource limited setting. And for me, that was a very profound experience, and one that highlighted for me the incredible burden of critical neurologic illness worldwide, and the severe resource gaps that limit care delivery for that very needy population in much of the world. And that has become the focus of my academic interest in medicine, is finding ways to increase capacity for acute neurologic care in resource limited settings.
Great, thanks so much. And how did you two cross paths or kind of get connected to work on the project we're going to be discussing?
Well, Dr. Hassan and I have been working together for almost the past 3 years, 2.5 years or so. We were connected through various colleagues in the Neurocritical Care Society, and began working together on this project with a specific emphasis on ENLS and how its performance might be improved in low and middle income countries where the resources for managing neurologic emergencies are not as widely available.
Okay. And Dr. Hassan, can you tell me a little bit about what research has gone on in your nation or in Africa to tell us like we need better programs or better way of implementing education?
Yeah, there are very few research that has actually gone on to know what the problem, what the resource need is. And I know of one particular paper that was published to look at the critical care needs of hospitals and centers in resource-limited centers, particularly in Nigeria. And it just showed that we are lacking quite a lot in management of virtually all critical care cases, and particularly the time interval between an incident and the time that the patient gets to the hospital is very critical. In most cases, EMS is not available, and so patients don't get to the hospitals on time. And that alters quite a lot of things, because you see patients get into hospital after several days of an acute emergency. And so the treatment, it now becomes a challenge trying to use algorithms that are meant to be used within the first hour of treatment. And that's largely the case in most sub-Saharan African setting. And certainly Nigeria is, that's a major problem that we face.
Yeah, I mean, certainly you have to change the way you treat people if you're seeing them in a totally different part of their disease state.
Exactly.
And when did you, I guess, start planning for this course?
Well, the planning started almost 2.5 years ago. It was slow because a lot of logistics have to be taken. This is the first time such a course is going to hold in Nigeria. And so we didn't have a prior knowledge of how it was going to be conducted. But with the guidance of Morgan and the members of the Neurocritical Care Society, and also we have been running courses on BLS, ACLS, and PALS in the last 10 years. So we thought it will be easy to integrate this. It's just new. We have not had anything like this. And so and it is something that we know we really need. Neurocritical care in the acute setting is almost, I don't want to use the word non-existent. It is there, but there are no rigid guidelines that are followed. Different centers do different things, and we need that coordination. So ENLS, we believe, will bring that coordination for us, and so that we do things almost uniformly across board. At the moment, that is not the case. Most centers will have highly trained specialists in the different specialties from different backgrounds, having done their training outside Nigeria or done fellowships in different countries, coming back. And so it's those individual experiences that the individual uses. So it differs from one center to another center. So we need a uniform platform that we can say we are treating these patients based on these guidelines. At the moment, that's not the case. And so it's difficult to compare what one center is, the results from one center to another center. And resource limitation is across board, and different cities will have different challenges. So I think it's the ENLS will help give us a platform where all of us can have a guideline that we will use to improve neurocritical care within our various locations.
Great. So before we talk about the course that took place in July, I just wanted to know if there were any challenges you encountered as you were planning for it.
Well, one of the things that was very important to us is, Dr. Hassan has just spoken about the heterogeneity of resource availability across sub-Saharan Africa and really across the spectrum of low and middle income countries around the world. And one of the things that was important to us was to try to capture that heterogeneity by including participants not just from Aminu Kano Teaching Hospital in Nigeria, which is one of the largest teaching hospitals in Nigeria, but also having involvement from healthcare workers across the continent of Africa. And so one of the, I'm not sure I would call it a challenge, but one of the priorities that we worked very hard on was recruiting a broad sample of participants that could join us remotely over Zoom for a 2-day live training event. And our purpose in that event was to not simply provide training to healthcare workers, but also to collect data from them throughout the course on the specific resource limitations that that impaired the applicability of management guidelines to their own practice setting. And so we engaged in a very broad outreach campaign among personal and professional networks throughout Africa to include as many healthcare workers as possible, and we were able to include folks from over 20 countries, and representing I think the full spectrum of resource availability within large African hospitals. And one of our priorities now is to incorporate that range of resource limitation and resource availability into a set of guidelines that can be more flexible. So rather than having one cut and dried management algorithm, what we're striving to do as we process the data we collected during the course is to is to create management algorithms that can accommodate 2 or even 3 tiers of resource availability to make optimal use of available resources within a given setting.
Great. So, I mean, you kind of answered my next question, which is going to be why the hybrid model. It seems like that was just to capture the full spectrum of resources on the continent. But what was the background of the attendees? Was it a mix of physicians and non-physicians?
That's right. It was, I would say it was a relatively even mix of physicians, nurses, physiotherapists who play a very important role in the healthcare delivery systems in much of sub-Saharan Africa, as well as a smattering of other backgrounds, including non-neurologists, trainees of various types. And I'll just say that the enthusiasm that we had from the folks that we recruited for the event was incredible, and I think that it spoke to a real desire and hunger for this knowledge and training, and for the incredible potential energy that exists for broadening the healthcare workforce through platforms like ENLS.
And what kind of support was needed, whether it was like on the ground logistical support or people remotely to help? Like, I'm sure it was a lot of planning that went into getting this completed.
There was a lot of planning. We had incredible support from the Neurocritical Care Society. I'll give special thanks to Becca Stickney, who's one of the education coordinators within NCS, who really took a leading role in managing the logistics of the course and helping to problem solve issues as they arose. During the actual course itself, at AKTH in Nigeria, we had a couple of power failures that required us to be flexible in terms of our course delivery and our incorporation of our remote participants. And with the help of our NCS team, we were able to manage that flexibly and smoothly, and get through our 2-day course without any major obstacles.
And were the people in person teaching a mix of people that were NCS faculty that came from abroad, in addition to local physicians?
So I had the opportunity to travel to Kano to be one of the course directors. My dear colleague Susan Yeager, who's been serving as the treasurer of NCS, came with me, and so we, along with Dr. Hassan and a couple of our other colleagues at AKTH, served as the in-person course directors. And we were fortunate to have a wide variety of faculty members who took the time to pre-record lectures for the course, and so we were able to deliver the course through screening of pre-recorded lectures and then real-time discussion between modules about particular management questions.
Is there anything you think either of you would have done differently if you were to be able to go back and plan things any differently than you did?
I think that there were, as with any live training event, there were little hiccups along the way, but I really think that the attendance and enthusiasm that we had throughout the course was amazing. And we had wonderful energy, not just in our lecture hall in Nigeria, but among the many virtual participants as well. And I think that all of the planning that we did in the months leading up to the event helped it be a smooth and successful event. And I don't think that there were any critical issues. And I think it was encouraging that this type of thing is feasible and possible to do with fairly limited resources, and just taking the time to carefully plan the event.
And now I know you alluded to collecting some data. Are you able to share any of the preliminary findings, or are you going to keep that for a later time?
Well, the data that we collected is currently being digested and processed among a large working group that we established during the 2-day event in Nigeria. And so one of the things that we did during that event was to recruit individual healthcare workers who are interested in engaging more on this topic. And so we now have a working group that includes not just Dr. Hassan and me and the various other colleagues that were involved in the planning of the event, but also healthcare workers from 7 or 8 sub-Saharan African countries, and we meet on a weekly or bi-weekly basis to tackle individual modules of ENLS based on the data that we collected during the course. And what we're currently doing is creating evidence-based management algorithms that reflect the resource constraints among the participants in our sample, and create flow diagrams and narratives of care that allow workers in resource limited settings to navigate the limitations that that commonly hamper their ability to use the existing ENLS modules on their face.
Okay, so it seems like right now you're kind of working on generating updated guidelines for places that might not have the resources that the initial guidelines were intended for. Do you think there'll be another course in the near future?
Well, right now we're working on creating content that can be incorporated into the next version of ENLS, and quite what that's going to look like is still under discussion in terms of how we incorporate the resource limited content into the overall course content. But I think the next phase of this project would be to once that content is created and those materials are made public, would be to hold a subsequent course to essentially pilot the innovations that we've made to the resource limited curriculum and collect data on the perceived applicability in sub-Saharan Africa and other resource limited settings, and see whether further adjustments need to be made. And so what we're currently in the process of creating is what we see as a first draft of this effort, and I think that there's going to be multiple subsequent iterations that help us fine-tune the content and make it as applicable as possible.
For the adaptation of the ENLS, I'm just curious, do you think you will keep all the current modules, or are there any other disease processes that we might not see as often here that's more relevant there that you came across that you might want to include?
Well, the existing ENLS curriculum really does provide a comprehensive coverage of the full range of neurocritical care disease entities, and it's rather than expanding the content, what we have some mind toward is taking out elements that simply are not going to be useful for people working in resource limited environments, and trying to tailor the algorithms to be as faithful to the existing realities. And so, for example, the pharmacotherapy module in ENLS is something that we're not going to be deliberating on too exhaustively, simply because the medications that are prescribed within that module are largely not available outside of high-income country settings.
Okay. So what advice would you have for people that either want to be involved in this project or get involved in similar projects to address gaps that exist in healthcare practice?
Well, I have some thoughts on this. I'm going to let Dr. Hassan talk about this as well, because he is really integrated within the African neurosurgery and African medical community writ large, and I think can speak more eloquently than I can about how to involve healthcare workers from resource limited backgrounds.
Well, thank you very much, Morgan. Really, it's the course we had was an eye-opener, and we have seen an enthusiasm from people. Initially, when we tried to recruit, we had almost 500 people wanting to join the course. And that large number, obviously, for the first time, was not possible. We had to limit that number. And that shows that really, if this course is continued, there will be a lot of benefit, and we'll be able to reach more people. And so there's need for more of such courses, and to make it more widespread. One thing that is lacking in the countries that we have been able to reach, no Francophone countries are involved. So largely all the countries that are participating are English-speaking countries. So we have not reached the French-speaking countries. And within the participants of the course that were able to come in-house, there's just a tiny fraction of participants that could make it to the course because the time we gave was not enough for some people to disengage and come. So looking at what we are doing currently, there's an urgent need for us to have a streamlined way of looking at neurocritical care and having a well-researched data like this one we are working with to assist people in carrying out the daily management of patients with neurocritical care disease. We didn't have much challenge. That's probably because of a long time planning and the support from the Neurocritical Care Society. So the biggest challenge that will come if we want to reach a wide area of Africa is the issue of cost. How will participants be able to pay for such costs? This current one was at no cost to the participants, and that helped us to get quite a number of people. Now, if there's a cost to it, you may have very few people that will actually be able to pay for such a cost. So if it can be made free or at a low cost, we believe a lot of people will be able to access the course and also maybe get certified and will be able to have a pool of local trainers that will continue to carry out such courses at a local level. There's need for it to be done regularly because just one of a course just done once will not be enough. I believe if we do it yearly, we will be able to reach a wide spread of people that will be willing to maybe change the way they do things. I have been looking at how do we get this across to all people involved in neurocritical care. There's no one platform. We have to use societies, we have to use social media and publications possibly to be able to reach as wide audience as possible. There's definite need for change. There's the Neurocritical Care Society or this project going on will only be able to achieve just a tiny bit. There are other factors that governments have to be involved. For instance, providing emergency medical services to transport patients to hospital quickly. A lot of education needs to go out to the public of the need to get patients to hospital early. That needs to be done. I have not worked out how we can do that, but that's what affects all diseases in Africa. It is worst with neurocritical care because often you have patients with altered level of consciousness. And in Africa, if anybody has altered level of consciousness, the general population will start thinking of possible, they will bring in things as supernatural causes to it. Supernatural, traditional means of treatment, religion, all those factors will prevent patients getting to hospital on time. And when they get to hospital now, the issue is where are the resources? A lot of the drugs in the ENLS module are not available. And so, this algorithm that is being produced will have to look at how do we navigate the absence of such medications, other forms of treatment like controlling an aneurysm, for instance, early. There are few centers that can do that effectively and routinely. How do we get those things available So it's quite a lot of work. The ENLS algorithms and the protocols will assist in knowing which areas need to be developed. The other things will now be left for governments and health management systems to improve on.
And I'll just add, I think that having a local champion who can serve in a leadership position for efforts like this is incredibly important. And at AKTH, Dr. Hassan is a clear leader. I also want to just mention our other colleagues, Dr. Mustafa Miko, who's one of the directors of anesthesiology at AKTH, and Halima Salisu Kabara, who's a critical care nursing educator. They really have formed the nucleus of our leadership team at AKTH, and really it comes down to individuals like them who have the dedication and expertise to help make things like this happen, and to provide the knowledge and expertise that are foundational to the educational process. And I think that moving forward, forming networks where these collaborations can be coordinated and grown, at multiple sites is the next step to create, more of a consortium that can lead to innovation and sharing of ideas. And then, on the high income country side, like the United States and Europe, I think, there's a tremendous amount of enthusiasm among our trainees in neurology and neurocritical care for global health work. And so it's really been one of the great joys of my career as a faculty at Yale over the last few years to be able to mentor medical students, neurology residents, neurocritical care fellows who are interested in global health, to get involved in projects like this and other capacity building projects in low and middle income countries. And so I think that there's really no shortage of enthusiasm and energy out there, both in countries like Nigeria and Zambia, and also among trainees in the United States. And one of our hopes for this project is not simply to create a resource limited set of guidelines for ENLS, but also to serve as a platform in which further conversations can be had about how do we improve neurologic care in resource limited countries.
Certainly. I mean, Dr. Hassan, you brought up a lot of excellent points where it goes beyond just educational initiatives, and there's, emergency medical transportation services and governmental support that goes into it. So certainly a lot of work to be done. Any final words you'd like to share with our listeners?
I'll just say that this project and other global health projects that I've been involved with are profoundly rewarding, not simply for the ability to make small differences in neurocritical care delivery, but also for the opportunity to make connections like the one that I've made with Dr. Hassan over the last couple of years, and our other colleagues, and that really everybody who is working in this space is motivated by the desire to act selflessly to improve healthcare worldwide, and I think that self-selects for a certain type of person that is really wonderful to work with, and so for anybody who might be listening who's interested in this type of work, I just want to extend a warm welcome, and happy to talk with anybody further about ways to get involved in this type of thing.
Thank you. Going through this process has actually made me to question myself. How have I been managing critically ill neurologic patients? It has made me to question what are the processes out the way. How do we manage patients in general? And that has been the question I've been posing to my colleagues, the neurologists, the intensivists. Now, how do we come together to make the management of our patients better? It has been a challenge. We have been saying, yeah, we are not doing probably the best we could do, But this has really opened up quite a lot of, it has really educated us. And I think we are working at the local level to see how we will bring change first to our own hospital and see how we can export it to other teaching hospitals and the Africa as a whole. So there's a lot of work. I believe this is just the beginning. And we hope in the months or years to come, we will develop quite fast, since we now know what the limitations are, and we know what to do to improve in the different facets. So whatever is within our own capacity as healthcare workers and educators, we will be able to now form groups and develop on what we have learned from this whole process and how we can share it with our colleagues on the continent.
Well, thank you both for joining. I will make sure that we include a link to the article in the show notes. And to check out this or other Currents content, head to currents.neurocriticalcare.org. As a reminder, NCS offers free CME for select podcasts. Listen via the NCS Learning Center and complete a short survey to receive your credits. Otherwise, you can access the NCS podcast wherever you get your pods. Don't forget to add us to your favorites to make sure you never miss an episode.